Thursday's lecture. And then you have 3 more lectures next week. And then you have another quiz on the 27th, and followed by 3 or 4 lectures. And then you're going to have the final the exam week that starts on May 7th, and the exam hall is scheduled for May 11th. This is the final hourly exam with Medicam 2. So most of you should be done by then, unless those students who need, who were excused, will have to take a cumulative final exam that will be scheduled during the summer. But those are only for students who have been excused. Only a couple students we will need to do that. So most of you, all of you actually, with the exception of those couple, will not need to take a cumulative final, okay? And also for those students who are not doing well, you do not have the option of taking a cumulative final in this class, so just to be clear, all right? So make sure that you study hard for the exam 3 left and also the exam 4, because you do not have another chance. Just like the Medicam 1, we have an optional cumulative final. But in this case, we just have 4 sectional exams that you have to perform, and then you will be assigned a grade. All right, so this is done. So these are the classes of drugs that we will cover in the CNS depressants. So today we are going to be looking at general anesthetics. Of course, we're starting mainly just focusing on inhalation general anesthetics. And we will continue the discussion of general anesthetics, IV general anesthetics, I think after the exam 3. And the second class of drug molecules that we will talk about is sedatives, hypnotics, and anxiolytic agents. And then the third class is the skeletal muscle relaxants. And the fourth is antipsychotic drugs. And the last one will be on the anti-epileptic drug molecules. So these are the 5 classes of drug molecules that we will discuss over the next 9 lectures. So for general anesthetics, there are 2 types, of course. The 2 types that we will be focusing on have inhalation anesthetics, and then you have intravenous anesthetics. So these 2 types differ, of course, by the route of administration. The inhalation, of course, patients are breathing in either gas or volatile liquids. Okay, so those are the classes of, those are the drug molecules that we will discuss today. We're talking about gases and volatile liquids, and they are usually all highly lipophilic. And then, of course, the intravenous ones that are given by IV administration. So there are advantages of both types, and oftentimes it's a combination in order to use the advantage of both types. So in pharmaceutical chemistry, we discussed briefly in terms of structurally specific and structurally non-specific drugs, right? So all the drugs that you have learned so far, most of them are structurally specific. So that means they target certain enzyme receptors. There are specific binding sites the drug molecules will have to bind to produce their activity. And the inhalation general anesthetics, at least some of those are considered to be structurally non-specific, okay? So that means they rely on their lipophilicity to produce their activity. Once they are administered, they go into the central nervous system very quickly, and then, of course, that relies on their lipophilicity, and then they occupy certain spaces in the central nervous system and probably block some of the signal transduction pathways in the central nervous system and produce general anesthesia. So what are the mechanisms then? The mechanisms of how these drugs work in terms of their lipophilicity, right, being the most important factor, is not very clear, right? So there are some hypotheses that how they work. The first one is basically the lipid hypothesis that started probably many years ago. We're talking about 120 plus years ago. This hypothesis is Mayer-Overton hypothesis. Just looking at the really the lipophilicity of the drug molecule, but then this doesn't really explain everything, right? Because you have drug molecules that are increasing lipophilicity, but then their anesthetic activity doesn't increase as much. And then there is the modification in the 1950s, the Mullins modification. So in that case, then they're talking about the volume of the drug molecules occupied. So that means we don't really know how they work, but we do know that these molecules rely heavily on their lipophilicity. They get into the central nervous system and then block probably certain signal transduction pathways. So then there is the protein hypothesis, right? Protein hypothesis is getting closer to the structurally specific drugs. So we are looking at, well, there may be certain receptors, maybe in the area of those receptors that these molecules go to and then block, affect the actions of those receptors. But still different from the structurally specific, there are defined binding sites. Right here, we are having less, but it's affecting probably certain receptors in the signal transduction pathway. So this is more recent. So these are kind of the mechanism of action that people have, scientists have kind of used to explain the mechanism of action. And then I'm going to mention a little bit about the stages of anesthesia, right? So when we anesthesia, of course, we are trying to put the patients under condition they are kind of unconscious, right? So they are going to be able to be operated on, like for surgery. So when this happens, when the administration of the general anesthetics being used, there is a dose-dependent effect, right? Initially, there will be stages. Now, this is, of course, 4 stages defined based on traditional, or like one of the oldest drug molecules that's being used in the clinic. So we're talking about diethyl ether, right? So this was a general anesthetic that was probably the first one, like inhalation general anesthetic. We all know what diethyl ether is, right? There's an oxygen on both sides. You have CH3, CH2, so it's an ethyl group. So it's just 2 carbons on each side, so that's diethyl ether. Diethyl ether has relatively low boiling point, so it's very volatile, about 34 degrees Celsius in terms of its boiling point. So when you have, in the past, what the doctors did, just use, let's say, sponge or some cotton, right? And then you dip into the diethyl ether and then it evaporates and basically have the patient breathe in the vapor of the diethyl ether that can help with patients, knocking patients out basically for surgical procedures. So depending on the doses used, the initial stage is analgesia. So that means insensitivity to pain, right? So it's just induction phase, more or less, the analgesia. As you increase the dose, there is another stage for stage 2, which is excitement. But in stage 1, patients are still conscious, right? So they still know what's going on around them. But in stage 2, they still probably, stage 2, there are excitement, and there are some loss of memory, so in amnesia, irregular respiration, and sometimes even causes vomiting. But this is the stage some of the newer generation of drugs probably have less of, right? So this is not a stage you want the patient to stay in. And then there is stage 3, which is surgical operations can kind of occur when these patients resume regular respiration and they basically are unconscious. They don't feel the pain associated with the operations. If you continue to increase the dose, that will lead to stage 4, which is really general CNS depression, too much of the CNS depression. Respiration can stop, right? So this is the stage you do not want to reach. So that's why in anesthesia or in operations, you always have an anesthesiologist around, right? So you want to control the dose that's being used. You never want to reach this medullary depression stage that can really stop patients breathing, and that can cause really a lot of cause problems, the overdose. Now again, this is classified based on the initial, the first general anesthetic agent, that's diethyl ether. Diethyl ether, as you know, is no longer used nowadays in the clinic, and it's being replaced by much better agents. But still, you can see the dose response effects of the agents being used. So in order for to develop an inhalation general anesthetic, right? What are the ideal characteristics? What do you want in an ideal general inhalation anesthetic? So these are the 7 criteria that you are looking for, right? The first one is non-flammable. And this is mainly due to like the initial ones that's being used, diethyl ether, because it's carbon, hydrogen, right? If you have oxygen around you, you have a spark, it can explode. So that's the problem with flammability of those agents. So you want it to be non-flammable, and it should have good chemical and metabolic stability. So it doesn't metabolize so much, and it should be stable. And then low incidence of myocardial events, like effects. No incidence of hepatic and renal damage. So we're talking about toxicity, right? We don't want to have these drugs to have really lasting toxic effects. And then you have rapid induction and emergence from anesthesia. You want the anesthesia to stop very quickly, right, as needed. And then you want the anesthetic effects to go away when you say after the operation is done. And then adequate skeletal muscle relaxation. So this is an important criteria because when you operate on patients, you do not really want patients to be tense, like the muscles, right, kind of tense. You want to have patients relax. It's easier to do it that way. And sometimes without the effects, desired effects of skeletal muscle relaxation, you can add, of course, skeletal muscle relaxant. But here, you hopefully, like the general anesthetic would have that, and then wide margin of safety. So these are the 7 inhalation criteria ideal for an ideal inhalation general anesthetic. So currently, drug used as inhalation general anesthetic in the clinic, none of those would meet these criteria. So that's why what we need to use often in the clinic is a combination of agents, right? As you'll see, that can be an induction, say, caused by intravenous general anesthetic, because it's faster onset. And then followed by, like inhalation general anesthetic, kind of maintain the anesthetic effects. And once it's done, you just withdraw, like the gases, or withdraw the inhalation general anesthetic as the patients wake up. So this is one important point. So these are 7 criteria that you want to have in an ideal inhalation general anesthetic. But oftentimes, and you have to use combination. So combination is often used. And then the duration, the other point I want to point out, the duration of general anesthetic is often also affected by another characteristic we often see is blood gas partition coefficient. So this is B, G, P, C, right? Partition coefficient. So for many of the inhalation general anesthetics, I'll give you these blood gas partition coefficient. So what does it mean? So when it's a smaller number, say for example, of course when it's 1 to 1, like it's a 1. So if it's say 0.5, so that means in the blood, when you have the equivalent in the blood, you have twice as much in the gas than in the blood. Because what you're looking at is the general anesthetic in the vapor phase in the lungs, and then that participate between the gas phase and the blood around the lungs, right? So when you have a low blood gas partition coefficient, so that means when you withdraw the inhalation general anesthetic, the drugs will partition into the gas phase and be breathed out. So you would have shorter duration of action because it's much easier to breathe them out. So this is an important characteristic that we will mention. Of course, if you have a larger one, right, a number BGPC larger than 1.0, so that means it partitions more into the blood. And when you withdraw the inhalation general anesthetic, it will take a little bit longer for all the general anesthetic being cleared through the vapor, through the breathing out route. So the other characteristics, the general anesthetics, so the other characteristic properties I often need to mention is called MAC, right? MAC, M here is the minimum number. So it's a minimum alveolar concentration. alveolar concentration, this concentration that's required to produce 50% of the patients the desired anesthetic effects. So it's a 50% number, right? So it's like the EC50 that we often use in comparing drug potency. So this is MAC, it's a potency number, right? When MAC, you say, is 50%. So that means, let's just use the number, say 10%, rather than confusing the 50, okay? So let's say MAC is 10%. So that means the drug concentration in the vapor needs to be 10% in order to produce the general anesthetic effects in 50% of the patients. All right? Okay. So that's what this means. So the higher the number, the weaker the general anesthetic. The smaller the number, for some of the effects you'll see later on, like the more potent general anesthetics, they probably have less than 1% is needed to produce the desired anesthetic effects in 50% of the patients. And for some of the molecules that you'll see next, you require more than 100%. Okay? So let's look at the next page. So remember, there is an MAC I will also give you. So the first drug molecule that we're going to be talking about is probably the simplest, right? Just laughing gas, nitrous oxide, N2O. So this is the molecular formula, 3 atoms, 2 nitrogen, 1 oxygen. So it's nitrous oxide. This is probably one of the oldest general anesthetic, comparable to be around the same time when diethyl ether was kind of discovered to have the anesthetic effects. So between the two, sometimes you would say diethyl ether is probably a year or two before nitrous oxide in the 1800s, okay, when it's first used. This is a drug molecule that has a let's say BGPC, right, blood gas partition coefficient of 0.47, right, less than, around 0.5. So that means when you have equilibrium, we are looking at more of the gas in the gas phase than in the blood, right? And then MAC of this drug molecule is 104%. You might wonder why can there be 104? You cannot be more than 100, right? We cannot even use 100%. Why? We need oxygen, right? So you need at least about 20% oxygen. You probably can use up to 80%. So that means just using nitrous oxide, it's not going to produce sufficient general anesthetic effects. And that's why the first experiment, first demonstration in Harvard in 1845 was considered a failure because a dentist was trying to use laughing gas to give to the patient and then extract a tooth from the patient during that time. And the patient, of course, groaned during the demonstration. So many doctors at the time said, this is not effective, this is not good, because you did not produce the desired anesthetic effects. And the patients were feeling the pain, right? So that means because at the time, you know you need more than 100% to produce 50% general anesthetic effects. So that means we are using even 80%. It's not sufficient. The dose was not sufficient. But there are certain advantages of this drug molecule, right? So this is a gas at room temperature. It has good analgesic properties, but weak anesthetic activity, right? So insensitivity to pain, pretty good, but then in terms of the amount required to produce anesthetic effect, needs a lot more than that. And this also does not produce skeletal muscle relaxation, right? So that's a no skeletal muscle relaxation for this drug molecule. But for surgery, we need to use it in combination with other agents because we can only up to about 80% nitrous oxide and oxygen is needed for patients. The other advantage is it's safe, quick onset, so we're looking at 20 seconds of onset of patient's effects, and also has fast recovery. Another advantage, no hangover effects, right? Oftentimes you hear patients going through general anesthesia and they feel it afterwards, but this one, right? After patients finish using it, they don't feel really much, in terms of the effects, lingering effects. So this is a very kind of a safe drug molecule. And of course, this 104% just indicate the activity is very weak, right? This is a projected number, right? Just based on the dose response of the increase in order to produce 50%. So you need more or less 100% of the air in the patient's lungs to be replaced with nitrous oxide, but that's not practical. Okay, so this is nitrous oxide. So oftentimes it is a drug that's used. If you look at the general anesthetic machine, that I have a picture and also a YouTube video that I want you to watch, right? So it's also on canvas. So you can watch it, it's always there, but it needs to be in a cylinder. It's a gas, right? So the cylinder is always there in the general anesthetic machine because of the safety of this drug molecule. So it's still being used. This has been used more than 150 years, 150, or maybe 170 or 180 years now. So the next two drug molecules, they are not being used, but I wanted to talk a little bit about these two alkanes, right? So one is cyclopropane, the other one is ethylene. And of course, these are all gases. These are all gases, simple alkanes, carbon, hydrogen. So these do have more potent general anesthetic effects. So if we look at MAC, 17.5% for cyclopropane, and then this is about 80%. So ethylene is weaker as a general anesthetic, cyclopropane is much more stronger. Then they also, like cyclopropane, an advantage, it does produce skeletal muscle relaxation, while ethylene does not. They no skeletal muscle relaxation. But the other problem with these two gases, right? First of all, storage. You have to have a gas cylinder. And also the other problem with carbon hydrogen alkanes, if you have a flame around, it's going to burn. It can cause explosion. Okay? So that's another major issue with this. So you can have explosion that can happen if you have flame around. So this is not something that, like these two drugs that we design. So they are probably, you don't see them anymore in the clinic. So that's about that I want to talk about. But then if you look at, say, well, how do we improve them, right? Because they have general anesthetic properties, and they are gases. Can we make them better? So one way to make them better is make them heavier, right? So that means we can replace some of the hydrogens with halogens. So that's why the next drug molecule is important. So now we are coming into the next class of molecules called volatile liquid general anesthetics. So that means these drug molecules are no longer gases. You do not need a gas cylinder to store them. They're going to be in, like say, a little bottle, right? But they're volatile enough. So that means volatile, that means it can quickly be swept away by gases, like air, and can bring it to the patient's airways, right? So then what you see is, this is the structure of halothane. This is the prototype. This is actually was used in the clinic, but now no longer used. But you see the difference between the halothane and the ethylene, or earlier the alkanes, is you have all these halogens. You have 3 fluorine, 1 bromine, and 1 chlorine atom, replacing the hydrogen of in the ethylene, ethane, because it's saturated. So ethane would be a gas. But if you replace the hydrogen with halogens, because you have polar dipole interactions between the molecules, they can tend to stick to each other, and then it becomes like a liquid. So in this case, this is a liquid, so we're looking at a boiling point. Another characteristic that you'll see, about 50 degrees Celsius, right? So that means it's a liquid. And because it has high vapor pressure, so you can bring it to the patient's airways. So this is boiling point. And then you have blood gas partition coefficient, in this case of 2.5. So that means it favors the blood, right? So it's going to go into the blood more than the gas phase. And then you look at the MAC, minimum alveolar concentration required to produce 50% anesthetic effects in patients. So we're looking at 0.74%, less than 1%, right? So this is one of the most potent general anesthetic that's belong to the inhalation general anesthetic. This is the most potent we're looking at. But there are problems with this drug, right? So metabolism is a major issue. So you'll see 20% of the drug is going to be decomposed or metabolized into, this is trifluoroacetic acid, and you have release of the bromide and chloride ion, and also, I think at the end here, you have fluoride ion. So these halogens and also trifluoroacetic acid this is a corrosive, strong acid, and the halides can cause cardiac effects, and then also fluorides can cause effects in the kidney, and that's going to be toxic, right? So there are more issues with these drug molecules, although it's probably the most potent general anesthetic known through this, the inhalation route. And this drug is causing a lot of hepatic necrosis, and also can cause cardiac arrhythmias. So this drug is no longer used. It's now being replaced by better agents, right? So this is just replacing the hydrogens with halogens, making the molecules heavier and have them stick to each other so they become a liquid instead of gas at room temperature. So on the next page, and you see 4 volatile general anesthetic agents, right? So you have 4, you have enflurane, and you have isoflurane, and desflurane, and sevoflurane. So 4 inhalation general anesthetics. And they're all very similar, right? So the difference is, you see, they all have halogen substitution of methyl and an ethyl, and with an oxygen in between. So this is using the knowledge that we have seen probably before, using diethyl ether. Diethyl ether is a liquid at room temperature, 34 degrees. But now, if you reduce one of the ethyl groups to a methyl, you're going to have methyl ethyl ether, right? So the difference between methyl ethyl ether and diethyl ether is just the extra carbon with 2 hydrogens on it, on the right-hand side. So this molecule, methyl ethyl ether, the boiling point is 7.8 degrees Celsius. That's below room temperature. So that means if you have just methyl ethyl ether, it's gas, right? So they have to probably use cylinders. But the problem, again, with hydrogens and carbons, they're going to be explosive when you have oxygen around, when you have a flame. So it's going to be burned and cause an explosion. So that's not desired properties. So you see all these differences, right? All these 4 drugs just replacing the hydrogens over in methyl ethyl ether with fluorine and also chlorine atoms. No fluorine atoms, I think, right? So you see in the later ones, just fluorines. And then earlier ones has 2 chlorines in it. And the difference is to help increase basically making them into a liquid, right? So you are decreasing the boiling point, increasing the interactions between the molecules, so it's a liquid. So the boiling points are all going to be around room temperature or higher. So if you look at the boiling point of these molecules, we are looking at 56.5 degrees Celsius for enflurane, and then we have 48.5 degrees for isoflurane, and then you're going to have sevoflurane, 58.6 degrees, and then I left out desflurane, right? Desflurane is 23.5 degrees. That's just around room temperature, okay? That's the lowest among the 4. So that's why if you look at the bottles, because if you just have this desflurane in a glass bottle, it's going to evaporate very quickly. So that bottle cap is very different from the other bottles or the other fluorines, okay? So this is because desflurane has the lowest fluorine point among the 4 fluorines. There is a picture on the next page, and you see there is a cap which kind of forces the molecules inside the cap. So it's kind of a very tight seal, so it's going to be unique for this desflurane. That's important feature that I want to mention. And you also see that these molecules, some of them are contain chiral centers, right? 3 of the 4 contain chiral centers. The only one that doesn't have chiral centers is the last one, sevoflurane. So oftentimes when you look at drug molecules have chiral centers, if they're structurally specific, means one isomer is often more active than the other. But in this case, they're all used as racemic mixture. So that means stereochemistry is not that important here, right? So that means they rely on their lipophilicity. They go into like the central nervous system, across the blood-brain barrier, and get into the central nervous system, and occupy that space, just probably be sufficient, relying on their lipophilicity. So structurally, but not specific, that we are talking about. So this is then another feature among these molecules. And then the next thing I want to compare or like is blood gas partition coefficients, right? So this is the important feature related to duration of action. So blood gas partition coefficient for enflurane is 1.9, and then for isoflurane is 1.4, and then for desflurane we are looking at 0.42, and then for the sevoflurane we are looking at 0.68, right? So this is, we are looking at blood gas partition coefficients, right? So there are differences between them, but they are between probably 0.4 and about 2. So that's the relative partition coefficients between these. And more importantly, we are looking at the MAC, MAC, between these molecules. So MAC for enflurane, 1.7%. And then for isoflurane, it's 1.17%. And then for desflurane, we are looking at 6%. And then last one, sevoflurane, is 2.05%. So among the 4, which one is the weakest in terms of its potency? Desflurane, right? It's the weakest. That's 6%. It requires 6% in order to produce their therapeutic, like anesthetic effects. So this is another feature, right, between these different fluorines. So I'm comparing them, but kind of more discussing them around the same, okay? So that's one feature so then another characteristics that also shown on these metabolism. So you see the first one, enflurane, with metabolism is 5%. What is the percentage of metabolism for halothane? It's 20%, right? But we are reducing that to 5%. So this is a quarter of the halothane. And then the last one here is also 5%. But then between the middle two, isoflurane only has 0.2% metabolism. And then desflurane, that even has less. And I think it's less than 0.02% in terms of metabolism. So that means in terms of metabolism, in terms of toxicity, which one is the safest? Desflurane, right? Desflurane, we are looking at 0.02% in terms of metabolism. But you have to use more, 6%, because in order to produce the effects. In the potency, you can rank them, of course, potency for halothane is more potent, right? Because that has the MAC, which is 0.74%. So that's, halothane is the most potent. And then you're going to have, in terms of you're comparing the MACs. And then you're going to have basically these two, right? This one, and this is probably not much different. And then this, and then that, in terms of potency, right? And then in terms of toxicity, you're comparing the toxic effects in terms of the fluoride ions, in terms of the halides being released. So you're looking at this probably being the safest, and then this one, and then these two about the same. In terms of the safety, we're looking at hepatotoxicity, or like the fluoride toxicity. And then the other point I want to mention between these, in terms of the effects, is the onset, right? So I mentioned that laughing gas, in terms of its onset, about 20 seconds, right? That's very fast, 20 seconds. So in this case, the onset is slower for the fluorines. So for the enfluorine and isoflurane, these two are about the same in terms of onset. So we're looking at 7 to 10 minutes. Okay, for general anesthesia after this started, we need to wait about 7 to 10 minutes for the effects to start. And then in terms of the onset for desflurane, it's about 2 to 3 minutes. And then the onset for sevoflurane, this is the fastest onset. So we're looking at 1 to 2 minutes. Okay? So we have basically the onset for these fluorines in the range of minutes, a couple minutes to about 10 minutes in terms of their onsets. So when you compare IV general anesthetics with inhalation general anesthetics, the IVs are faster, right? Because they're usually probably less than a minute or about a minute in terms of the onset. But comparing with then laughing gas is shorter, right? It's faster in terms of onsets. So onset is, again, sevoflurane is the one that has the fastest onset with the shortest onset time. We're looking at 1 to 2 minutes. And also the other advantage, again, with the fluorines is its desired skeletal muscle relaxation properties. Okay, that's another important feature to consider, desired skeletal muscle relaxation properties. So all of these have that desired property, okay? And of course, all of these have relatively higher vapor pressure, so it will kind of release once you have the air passing through it, the bottom, and you're going to have some of the vapor going to bring to the patient's airways, right? And that's going to be sufficient to produce the general anesthetic effects. So again, looking at the, one other thing I want to mention is enfluorane. It's one of the, in this case, in the US, that's basically more or less discontinued. And probably due to, of course, the higher metabolism rate and probably the side effects. And because we have isoflurane is probably the most widely used, because the reason that I have to kind of discuss this because you have iso, that means it's the same formula. The difference is the arrangement of these atoms. It's an isomer of amphoraine, okay? To give you some perspective between these two. So this is a better drug than amphoraine, and this is probably the most widely used general anesthetic in the US. And then you, of course, have these advantages sometimes with another properties I should mention. So this is most widely used. And the desflurane, another property of this is its irritation to the airways. So not very useful for extended anesthesia or induction, because patients still feel it, right? So it's irritated to the airways in terms of desflurane. With sevoflurane, there is a pleasant smell associated with sevoflurane, so it can be kind of more acceptable to, for example, to the pediatric population, right? For patients that can kind of more tolerate sevoflurane. But the smell of this one, isoflurane, has a pungent smell. So it's a little bit different as compared, some differences between these different fluorines. And because we are using machines, right, we know that these fluorines, at least 3 that's currently used in the clinic, they differ in potency, differ in hepatotoxicity and kidney toxicity due to the fluoride ions. And also, they, in terms of duration of action, also differs. So that's why when you look at the bottles, they're used in the clinic, right? They're all color-coded. You don't want to mix them up. Okay? So these are very important, although the littlest one of the 4, right, is not used in the US. And you see the cap for this sevoflurane on the right. You see the cap is different, right, from the other. This is desflurane. Yeah, desflurane, I'm sorry. So on the right-hand side, so this is desflurane, has the lowest fluorine point. We're talking about 23.5, right, in terms of the fluorine points. So very close to room temperature. So the cap is not just like the other ones, which is very simple, like a plastic cap, right? But this one here, you have really a kind of pressure device to keep the molecules inside the bottle, because otherwise it's going to be slowly escaping because of the low boiling point. And you have then isoflurane, and you have then desflurane, you have then sevoflurane over here, which is the largest in its size, on the left-hand side. So all these fluorines are stored in a cool place, usually still around room temperature. And because you don't want to really store it under the sun, right? It will heat up the bottle, and then it can cause evaporation or probably issues with these agents. So we're looking at storage conditions between 15 and 30 degrees Celsius, and of course, again, some other features related to this is the fluoride ions, and also when you have chloride. And of course, the ones that's being used in the clinic no longer has the bromide release, right? So I just want to make sure, right? You see, we do not have bromide anymore. We only have chloride and isoflurane that's being used, and then you're going to have fluoride that's being can cause problems in terms of kidney and liver damage due to bioaccumulation. And of course, chloride can sense the heart and cause arrhythmias and other issues with the heart. So this is the comparison of the fluorines and how they are being used and how they're being stored. And of course, this is the machine that you see that uses these general anesthetic agents. And some of these fluorides may be stored here in the back. You're going to see a cylinder, which is the laughing gas. And of course, you always have oxygen cylinders, and you're going to have probably air that also kind of that's being used in the clinic. That fine adjustments and like the flow rate that kind of adjusts the dose being used. And also you can click on the link, and I think I also have a link on the canvas that you can click and you go and watch the YouTube video. And of course, it's not a downloaded video, and I'm not going to give you like any points for watching it, but it's something for your knowledge, just to learn about the general anesthetic instrument. Okay, so I'm going to stop here, and just a last